Since AIDS, acquired immune deficiency syndrome, was first recognized in the early 1980s, it is estimated that worldwide 35 million people have died of AIDS, and over 34 million are infected with HIV, or the human immunodeficiency virus, the virus causing AIDS. In the U.S., over 1 million people aged 13 and over are living with HIV. Despite the size and consequences of this disease, we are a long way from controlling this infectious disease. We don't have a vaccine, and although our treatments are getting much better, they are far from where we would like them to be. The question is, why haven't we made more progress? And what do we have to do to prevent, control, treat, and eliminate this devastating disease? We'll try to answer those questions on today's episode of A Public Health Journal.
Welcome to A Public Health Journal, a program that explores the public health issues facing our society today and tomorrow. The host of our show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health, the Hennepin County Human Services and Public Health Department, and the Minnesota Public Health Association, all working together towards the goal of healthy people living and thriving in healthy communities.
Welcome to A Public Health Journal. Today we're going to look at the status of HIV/AIDS epidemic in the United States and Minnesota and discuss what needs to be done to control and eventually eliminate this disease from our country and state. Joining me in this conversation is Dr. Keith Henry, a physician at the Hennepin County Medical Center. And Dr. Henry started the first HIV clinic in Minnesota in 1985 and has dedicated his entire career to HIV care and clinical research in this area. Keith, welcome to the program.
Thank you, Ed. I appreciate the opportunity to discuss this still important topic.
Right, and thanks for all of your work over the years of really advocating for the best treatment and prevention for HIV. So let's start by just talking about what's the status of HIV in Minnesota and in the country. You know, like I said, we first heard about this disease and infection back in the early 1980s, and we've had a lot of efforts over the last several decades. Where are we right now in preventing and treating this disease?
Well, both nationally and in the state, we've suffered a lot over the years. Nationally, there's been almost 800,000 deaths and about 4,000 deaths in Minnesota. So that's the bad news, and the deaths were at a very rapid rate in the early years. In 1996, effective therapy was introduced, so we saw a dramatic decrease in deaths, still a lot of morbidity and remaining mortality. So the good news is we have treatment. The bad news is that people are still getting infected at a rate that's been fairly constant in the United States for the last decade. It's estimated we've had about a 20% drop in overall new cases per year in the United States over the last decade. Large drops in heterosexuals, IV drug users, but the main risk group remains men who have sex with men. And the rate both nationally and in Minnesota stays about the same. And for young men who have sex with men, the rate actually has tended to go up. And in certain minority groups, particularly African Americans, the rate remains astonishingly high in the U.S. And Minnesota is somewhat impacted by our large African population, which is also highly impacted. So we've made progress, but we've been very frustrated from the public health standpoint in that we haven't been able to decrease the new infections to much closer to zero.
All right, you put out a lot of statistics, and we have a little chart here that maybe graphically explains what's going on. Maybe you could walk through this, because this explains a lot about what you've been talking about.
Sure. So in Minnesota, you can see there's been a steady increase in the numbers of persons living with HIV. That's the dotted line. That's because people are still getting infected and they're not dying. So the death rate plummeted in 1996-97. That's that precipitous drop. So that was dramatic, but now people are living a long time. And if they're not on therapy, they can transmit potentially to other persons. So the new infection rate has remained fairly constant from 2014 to 2016, it went down in Minnesota about 4 or 5%, but in Minnesota it's been about almost a case a day, about 300 cases, and that's remained frustratingly about the same. So we have more people living with HIV, a fairly steady rate of new infections. The death rate has remained low, but hasn't gone away completely.
Mm-hmm. So why haven't we made more progress on some of these things? You know, it's nice that we have more people living with AIDS. I mean, treatment is effective, keeping them alive. But the deaths continue to be at a constant rate, and the infections at a constant rate. Why haven't we made more progress?
Well, again, buried in that question is some good news and bad news. The frustration is that if you're on therapy, and have a suppressed viral level on therapy, which happens most of the time these days when you're on treatment, you almost never transmit to another person. So what it's telling us, if we're having a steady rate of new infections, either two things are happening. You have people that don't know they're infected and can be transmitting, or you have people who know they're infected but are not on therapy and suppressed. And it turns out, at least at the national level, that anywhere between 60 and 70% of new infections are occurring from persons that are been diagnosed to be infected, but went to the doctor and then disappeared from care. So those are the out of care population. That's the main driver of the epidemic. Then you have persons that are unaware of their infection, and you have newly infected persons that would have no chance to know they're aware. So those are the populations that we have to do a better job with to drive our new infection rate closer to zero.
All right, so let's break that down a little bit. So there's been some recommendation from CDC nationally that everybody get tested for HIV. It's trying to get at the idea that there are a large number of folks, I don't know what the percentage is of people who are infected with HIV who don't know that they're infected. If we would universal screening help us at least deal with that issue?
It would. I mean, the estimates are kind of hard to firm up with good data on how many people are infected who don't know it. It often runs currently around 13 to 15%, or common estimates for many states throughout the country. If you had universal testing and it was actually implemented, that would go down a lot. And in fact, the CDC almost 10 years ago recommended everybody between the ages of 13 and 65, basically in the United States, have at least one HIV test in record, and then repeat tests based on their risk. But everybody should have at least one test. And in some places, one recent study out of the Bronx, they basically implemented a very aggressive electronic medical record-based system to identify who's not been tested. And when they did that, and the amount of testing went up dramatically, and the rate of new infections that were diagnosed has also gone up dramatically. So there are systems in place that we could do this, but unfortunately a lot of people are still not getting tested even that first time.
Mm-hmm. And why is that? Do they just don't understand the need for it, or they're hesitant about finding out?
Well, I think it's the responsibility is bidirectional. I mean, persons should ask, can I have an HIV test? But I think more importantly, the healthcare worker, the clinician, should be asking that question. And discussing sexuality, drug use, those are topics that are often awkward, and so they're often left to the end of the visit and dropped out of the conversation altogether. So I believe that the healthcare system and the clinician should be pushing that. And I do know that in Minnesota now, several of the health systems, including Health Partners and Hennepin Health System, now in their electronic medical record, have a prompt that if there's not an HIV test there, then it basically flags that, just like if you're 50 and haven't had a colonoscopy. There's now a flag, and we're hoping that that's going to be increasing the testing rate and the new diagnosis rate even here in Minnesota.
All right. The other point you talked about is people dropping out of care, and I want to get into that, but first we need to take a little break.
Okay.
So we'll be back right after this message. Welcome back. We're talking about HIV/AIDS with Dr. Keith Henry, an HIV specialist at the Hennepin County Medical Center. Keith, we talked about the people who didn't know that they are infected and how to do that. You also mentioned that there are a lot of people who know that they're infected but drop out of care. Why are people dropping out of care when it's so important to stay in care?
Well, that's true for lots of people, for lots of health conditions. HIV is concentrated in a lot of minority populations where there's a lot of poverty, so access to insurance has often been a problem. And all of the viewers know what it's like trying to work with the billing system. You show up, and if you have a bad interaction with the clinic, the doctor, the personality that you're working with, the billing system, often that'll drive a person away. They're often feeling stigmatized already because of their HIV infection. And so if you show up to a clinic a couple times and you think that someone's looking at you funny, or you get a bill you don't understand, you lose your job, you have unstable housing, you have mental health problems, chemical dependency issues, suddenly you have other priorities, and this has been a big problem for healthcare across the board, but particularly for HIV-infected patients.
Yeah. So it's a complex issue, and obviously it's not just about clinics. It's about how the whole system functions and
Correct.
how society functions, and the stigma. And we'll talk a little bit about stigma, but also there's one of the terms that has really come forward is that treatment as prevention. Tell us a little bit about what that means.
Right, so even in the early HIV treatment days with the first drug, AZT, it was shown that mothers who took AZT during their pregnancy decreased their transmission rate to their infants for vertical transmission, even with a relatively lousy single drug. More recently, with the more effective therapy, it's been shown that when you're on treatment and your viral levels are dropped to basically the undetectable level, usually less than 50 copies per milliliter, the risk to transmit to a sexual partner approaches zero. It's basically negligible. And that's been shown in a very large randomized trial that was published in the New England Journal of Medicine a number of years ago, and the 052 study where discordant couples, one who's positive, one who's negative, the positive person was put on therapy and looked at the risk of transmission to their partner. And once their viral load was undetectable, basically there were zero transmissions that took place. So that's where that treatment as prevention term came out, and why there's been this move to treat everybody not only for a clinical benefit but for a public health benefit. So it's a win-win. The patient wins because their health is protected, society wins because transmission is prevented.
Yeah. So if everybody got into care, into treatment, and maintained their treatment, we could actually decrease and eliminate transmission if we maintain people into care.
Absolutely, yep.
Right. I know you brought a slide here that talks about this therapy coverage on a global basis, and I think it's fairly impressive. Maybe you can walk through what this slide shows.
Sure. Well, most people are aware that most HIV infections in the world are in Africa, for example, which is a relatively poor, continent. And so it was said at the early days of effective therapy that you'll never be able to treat, persons in Africa with these expensive, complex drugs. But people started to try that, and the real breakthrough was with a program called PEPFAR, the President's Emergency Program for AIDS Relief, focusing mostly on Africa, where generic drugs were given to patients in Africa. And over the course of the last decade, they've achieved some remarkable successes where almost half the people in the world now, mostly in poor areas, and particularly in Africa, are now on therapy. And that's been very successful. It's turned the epidemic around in some areas. They've had a 50% drop in deaths in some areas. And so we're about halfway there internationally to achieving the goal of having everybody who's HIV infected to be on treatment. And the American taxpayer and many universities and government agencies have been very responsible for this amazing success, particularly in Africa.
All right, so on this slide, as you go along that horizontal axis and you see the bars going up, what does that stand for?
That's the number of people that are on therapy.
Okay, so as that goes up and then the curve coming down.
That's the number of people that are dying of AIDS, basically. And so this curve's been repeated. It was similar in Minnesota when we introduced effective therapy in Minnesota. We had that large drop in deaths. So it's been really a remarkable public health achievement, but we're only halfway there. But to sustain that, it's going to be very difficult in the current political and financial environment.
All right. So you've been working on this for a long time and continue to work on it as a leading advocate for the best approach. What do we need to do? What are the things that we really need to work on to really get ahead of this and actually eliminate this as a major public health problem?
Well, I think it starts with trying to still eliminate stigma. There's a lot of work. HIV has been considered a human rights issue as much as a public health issue. And so making people feel comfortable getting tested and coming to clinics and having society support them, for example, for men of sex with men population or transgender women, minorities, all of whom have stigma that they deal with. So addressing stigma remains very important. Having a rapid access to treatment. In some places, Haiti, Africa, San Francisco, they actually have clinics that the day you get diagnosed, you can show up and start treatment that day. That's actually been shown to be effective in many locations. Retaining those patients in care is also very, very important, so they don't drop out. So like it's true for every patient, making them feel welcome, friendly, making the billing understandable. That's an important aspect. And finally, for those who are at high risk, that are negative but could be infected in the future, there is a preventative treatment called PrEP, pre-exposure prophylaxis, that is being rolled out all over, including here in Minnesota. In some areas, for example, in San Francisco, an estimated 30 to 45% of all the high-risk uninfected persons are now on PrEP to prevent them from becoming infected in the future.
So you talked about access to care. Has the Affordable Care Act, when that was in place, helpful in actually getting people into care?
Absolutely. Again, there's a safety net system in the United States that helps a lot of areas and patients who don't have good resources. It's called the Ryan White Act, basically. Minnesota gets money to help care for HIV-infected patients that are uninsured or underinsured. That funding has been finite and has not been going up, and the drugs are expensive, and most of the money goes to pay for the drugs. With the rollout of the Affordable Care Act, a lot of those persons now had insurance that would cover at least the cost of their medications, which is about 75 to 85% of the total cost. So the monies can be spent on some of the very important wraparound services, such as for pharmacists, social workers, case managers, peer navigators, people that often don't get paid for in the standard billing system, but have been proven to be key to keep people in care and address their other social needs, such as housing, mental health, access to food, transportation, services like that.
All right, and I want to talk a little bit about what specifically can we do in Minnesota, but first we need to take another little break.
All right.
We'll be back right after this message. Welcome back. We're talking about HIV/AIDS in Minnesota with Keith Henry from the Hennepin County Medical Center. Keith, in the last segment that we have here, what do you see needs to happen in Minnesota? You talked about the stigma. How do we get at the stigma issue? How do we get people into care? How do we keep them in care? What are some of the thoughts that you've been working on this for 30 some years? What do you see as sort of the next steps?
Well, stigma is a very difficult subject to address. I don't have any magic bullets for that. Places that have been successful have tended to recruit persons from the impacted communities to basically not only go public with it, but to go out in the community itself and convince people that it's in their best interest to come and get tested and get in therapy. There's still lots of myths out there, so addressing some of the myths about HIV. I mean, people still say, isn't there a cure someplace? Wasn't it created by the government? The drugs are toxic. Again, we have, I think, 5 single tablet regimens right now, with several more in development. So the treatment actually has gotten often very simple, well tolerated and effective, and it's getting better all the time. So addressing both the stigma and the myths that are out there are important. The basic national AIDS strategy that you referenced earlier sets goals for a jurisdiction, and the current 2020 goal is to have 90% of people who are infected know about it, 90% of them going to the doctor regularly, and anywhere between 80 to 90% of them being effectively treated. And if you go across that spectrum, you can come up with how many people should be suppressed of the total population. And so there is one country, Sweden, that has already achieved the 2020 goal. They're at 90% identified, 90% care, 90% suppressed. Nationally, we're doing better, but it's probably no more than 50% nationally of everybody who's HIV infected are actually on therapy and suppressed. The most recent data from Minnesota on the website is a disappointing 53 to 55% suppressed of everybody that's been reported. Iowa, for example, is at 76%. So you have to really look at what the numbers are and then figure out with your limited resources where you get the biggest bang for your buck as far as addressing particularly the out of care issue. And for the state of Minnesota, it's in the metro area, particularly Hennepin County, is really the highest concentration. So I think that in Minnesota we need to have all the agencies work together to figure out how to replicate what's been successful elsewhere. For example, in San Francisco, to have campaigns addressing the stigma, more proactive, making rapid access to treatment and help them retain patients in therapy, and to have more aggressive PrEP campaigns.
Mm-hmm. So people talk about a cascade of care. What is that in terms of HIV care?
So again, the cascade of care is where you ask the question, how many people in your given population are infected? How many of them have been diagnosed and tested and diagnosed positive? How many of those persons have made a trip to the doctor at least one time? How many of them are going to the doctor regularly, retained in care, and are on treatment? Then finally, how many people that are on treatment have undetectable viral levels, so their health is protected and they won't be transmitting to other people. So that's the cascade, which is a very nice philosophy or approach to any medical condition whatsoever. And HIV has kind of been leading the field in that view of healthcare philosophy.
How about the real prevention vaccine? I mean, is there progress being made on a vaccine for HIV?
Well, that's been one of the difficult challenges for the HIV research field. There is no effective vaccine. There's been a huge search to find neutralizing antibodies that are effective against a wide range of virus. The virus mutates very quickly, and so it's actually being pursued by your immune system to try to trap the virus, and the virus changes and mutates. There is a vaccine trial starting in South Africa almost as we speak, funded by the U.S. government, that is taking the best of approach, and there's a lot of high hopes that it will be at least 50% effective, but only time will tell. But again, a vaccine that will be broadly available in the United States is a long way off still.
Mm-hmm. All right. I mean, you work in Hennepin County, and you said most of the cases are in Hennepin County, but this is a statewide issue. There's cases of HIV in rural communities also, right?
Right. About 86% of all the cases are in the metropolitan area. 15% are in, outstate, as we would call it. And one of the cool things about what's been going on in Minnesota that I've been impressed with is that the success in treating the out-of-metro area patients has been pretty good. That's often, in other states, you see a big drop-off in the success rate in treating patients that are not in the metropolitan areas. And there's been a long history of rural action efforts that have been pretty successful. So you have good care available in Rochester, Duluth, St. Cloud, and the Rural AIDS Action Network, RAN, which is here in Minnesota, one of the leaders nationally for kind of rural healthcare, has been pretty successful at helping rural HIV-infected patients get access to care.
Yeah. All right, in the last 30 seconds that we have, what are you doing in particular? Anything new that you're doing at Hennepin that is going to kind of help turn the curve?
Well, we're doing the large phase 3 study that's going to be using injection treatment. We're comparing a once-a-month injection for treatment compared to a daily pill. So there's lots of long-acting non-pill approaches that are being developed. And we're also doing one of the large PrEP studies where a new pill for PrEP smaller and safer as being compared to the current gold standard. So the research beat marches on. I would say our biggest difficulty is just having patients feel comfortable seeing us in clinic and staying in clinic still.
Right. Well, Keith, we've just scratched the surface of this huge problem, so thanks for being with us. And
my
informing
pleasure.
us.
I hope I get back within the next decade.
All right, very good. Well, I hope we get it resolved before then,
Yes.
but I have a feeling we're not going to. But
Right.
thanks
Thank
for
you.
all your work. I'll be back with a closing comment right after this message.
PrEP is an HIV prevention option that works by taking one pill every day. PrEP stands for pre-exposure prophylaxis. When taken every day, PrEP can provide a high level of protection against HIV and is even more effective when it is combined with condoms and other prevention tools. People who use PrEP should take the medicine every day and return to their healthcare provider every 3 months for follow-up and prescription refills.
The nation's first comprehensive national HIV/AIDS strategy for the United States was released in 2010. And in the subsequent 5 years, people and organizations have joined together around its vision and goals. The vision is that the United States will become a place where new HIV infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstances, will have unfettered access to high-quality, life-extending care free from stigma and discrimination. The strategy has already changed the way the American people are talking about HIV and how we are prioritizing and organizing prevention and care services and delivering clinical and non-clinical services that support people living with HIV. This new strategy has resulted in some important gains, but the level of infection is stable overall. While declines in diagnosis have occurred for women, persons who inject drugs, and heterosexuals, the epidemic among gay and bisexual men remains severe, with increases in new diagnoses. Achieving the goals of the national strategy will require intensified efforts for this population in order to realize the greatest impact. We as a nation have the tools to slow and eventually end the epidemic in the United States. What we need is ongoing leadership and sustained commitments to help get us to zero HIV infections. The National HIV/AIDS Strategy has provided us a roadmap for moving in that direction. We need people working together to make that happen. This coalition needs people living with AIDS, state, tribal, and local governments, healthcare providers, government and industry scientists, faith leaders, and community partners. It'll take the collective work of all of us to achieve the goal. Public health is defined as what we do collectively to assure the conditions in which people can be healthy. That's why HIV/AIDS is such an important public health problem. It's a problem that can only be addressed by all of us working collectively to resolve it. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.